So I just want to thank everyone for joining tonight. We're going to be discussing BK virus and your transplant and the effects it has. So thank you guys, everyone, for joining into the transplant journey with Dr. Marcus Pereira, the medical director of infectious disease at Columbia University Medical Center. We're incredibly fortunate to be having him join us tonight discussing the BK virus. He's been full of insight and he's spoken with us several times on a plethora of topics for us. And we're so fortunate to have him returning back yet again. And I know he's going to be full of so much insight and information. We have lots of you guys joining with us tonight, with I'm sure plenty of questions regarding BK virus because it affects many individuals with organ transplants. And I'm sure you guys have lots of pressing questions to come at him with. So I'm not going to take up any more time and I'm going to let Dr. Pereira take it away. And again, I appreciate the time and dedication that Dr. Pereira puts forward to protect the community. And again, all the other infectious disease doctors who really put their heart and soul into the community for all of us to look out for our best interests. And just Dr. Pereira, thank you again for always coming to our rescue and looking out for us because infectious disease affects so many transplant patients and what you've done for us during COVID and continued to do for all of us here. Thank you again for spending your time with us on a Thursday evening and have so much in the past and during COVID for looking out for us for vaccines and continue to look out for us for the vaccines moving forward. So, Dr. Pereira, please take it away.
Well, thank you, Jen, for those kind words. I might just say right back at you, thank you for everything that you do for your transplant friends and colleagues and for the community. I mean, putting this together is no easy task either. So thank you for being sort of the venue for everybody to sort of ask questions, support each other, and sometimes learn a little bit. And I know that I learn a lot when I come around. So this is obviously great for everyone, but it's nice to meet everyone. And for those that I've known before, it's nice to see you again. I see some familiar faces or familiar names. So let me just share my slides. Um, and I think, Jen, I think was kind enough to invite me. She really wanted a session on BK and transplant. And I have to say, I don't feel like much of an expert in BK, but I did take the chance to learn a lot for this talk. So thank you for in some. Oh, okay. I'm on mute. I'm not muted now. Okay. Anyways, I have a number of slides, and I know that all of you have a number of questions, and I know that Jen sent a number of really fabulous questions, and to the degree that I could, I incorporated them into the talk, but I have them all listed at the end, and really make sure that everybody feels like they at least answered to the best of my ability. So let me start with the presentation. I don't really have any disclosures as it pertains to BK. As you know, in the past, I mean, I've given some talks for some of the CMV medications, not for the companies themselves, but CME courses. But it's always good to know where your doctor is coming from and, what, if anything, that there's anything of conflict. So why are we talking about BK? Why was I asked to talk about BK? And I know that many of you are incredibly familiar with it, and have lived through it, and others have heard about it and sort of sometimes are dreading ever sort of having to deal with it, right? So as the way to make transplants work is balancing, sort of preventing rejection, but also trying to prevent infections. It's that balancing act that we've talked about it, right? On the one hand, you're giving immunosuppressive medications to prevent rejection while trying to avoid too much immunosuppression so that you don't have to deal with things like CMV or other infections, right? It's always, I don't envy the life of a transplant physician finding that art and what is the magic sort of doses for all those medications and what the actual medications ought to be for each of those patients. As I heard many of you talk about, it's incredibly individualized. There is no magic number that tells how immunosuppressed someone is. There are levels that one can follow, but it's an evolving field. People are trying to find sort of more objective ways to define immunosuppression, but as of now, we don't. So that's the balancing act that transplant providers and the patients themselves have to live through. But the reason why we talk about BK in the context of transplant is because it is an important virus. It is one of those viruses that unfortunately do impact, in particular, kidney transplant recipients. It's common, and therefore, physicians spend a lot of time having to deal with it, and patients themselves. So, what is BK? It's a member of this particular family of viruses called polyoma viruses. They're very large, complex viruses. They're made of DNA. So, so other viruses sort of in that general realm that are large and made of DNA would be something like CMV that we've talked about, EBV or Epstein-Barr virus, varicella, HSV, HHV6. These are sort of generally large, complex viruses that do have a lot of functions. They have an incredible ability to survive, to replicate, to transmit to other people. And they're not sort of your simple, in some ways, RSV, coronavirus, or even influenza. Obviously, those can be pretty gnarly and cause a lot of disease as well, but these are far more complicated viruses. BK is named after the first patient that was in which it was identified back in the 70s. BK virus is related to JC virus, which is another polyoma viruses that can cause a lot of problems in immunocompromised patients. JC virus is named after the patient that it was identified in. But unlike BK, JC, can cause some incredibly horrific and incurable diseases, something called PML, which is a neurologic condition of progressive, dementia that really is sort of almost end stage, right? Like if you have that, it's sort of pretty bad, and there is really no cure. But BK in some ways is, can be a little bit milder, and it just has different set of symptoms. BK is incredibly common. We usually catch it in our childhood years. Um, and the seroprevalence, meaning the number of people who have BK, rises with age. So it is estimated by the time someone reaches adulthood, whether, in their 20s, and certainly by the time they're in their 40s, it's almost about 90% of the population who has been infected with BK. Studies have shown this in terms of antibodies, that they're sort of turned positive to a massive degree by age sort of 30s and 40s. The way that we catch sort of the transmission it is from person to person. There is no animal reservoir. Nothing is hidden in terms of the BK. And it's really sort of mostly respiratory transmission, like sort of people are coughing. It's not a respiratory virus, but it can be in sort of respiratory droplets or in fecal oral or urinary oral transmission, which sounds pretty gross. But think about kids, right? Like they touch everything and they touch, they're playing around and then put things in their mouths and noses, right? So that's how we think BK is transmitted to people. But again, it's sort of, it's not sort of a respiratory infection that like you cough and there's certainly like an outbreak. So the thing about BK is, when kids catch it, it's not like we diagnose kids with BK, right? So they usually have maybe a fever, maybe they're slightly sick for a few days, or maybe less than a day, and quite honestly, the majority of these infections, kids are asymptomatic. So there is no diagnosis, much like CMV, EBV, and many other viruses. Kids catch, we don't know. We don't necessarily try to diagnose them with these infections. But what is important about BK, and in some ways similar to CMV, is that the virus is persistent, meaning after you get sick, it stays in the body. Our immune systems cannot cure us of BK. So you have this sort of primary BK infection, right? Like that's when you first get it. And it is sort of either of the respiratory tract, the oropharynx, sometimes gastrointestinal tract. Whether you have symptoms or not, it depends. But then there is a brief moment where BK is in the bloodstream and it has something of a preference for kidney cells. It infects either sort of the kidney tubules, the tubular cells, which is part of the nephron, that sort of draws electrolytes back and coordinates sort of, how urine is produced, or the uroepithelial cells, which is also part of that whole system. That's where it then stays, and it sort of establishes this lifelong latency. And I think many of you will be familiar. That's the same condition as CMV. Once you catch, it stays and it's there, it's dormant. And in the majority of people who are obviously not immunocompromised, they never know that they have BK and never have symptoms for the rest of their lives. It's like it never happened, right? It's not a relevant virus for the majority of the population. Now, there are some subpopulations, for example, it has been identified in women who are pregnant, for example. Sometimes, we can see low levels in someone who is elderly and very sick, or some people with HIV, or even in diabetics who are poorly controlled. There are cases where these are identified, but even in those patients, it's not like it causes any disease or it's something significant. The real exception, as you can imagine, and why we're talking about it today, is those who are more severely compromised, immunocompromised, in particular, solid organ transplant recipients and stem cell transplant recipients. Okay. But it really is very prominent in kidney transplant recipients, and we'll talk a little bit more about that. Why is BK important after kidney transplant? Well, I mean, it certainly has to do with immunosuppression. So it seems that the main arm of the immune system that it really establishes control over this virus, and it doesn't allow it to be out of sort of cause any major problems in the general population and even in other mildly immunosuppressed individuals, is the T cell responses, right? Sort of these are your CD4, CD8 cells, which are sort of the types of immune system cells that really control the whole apparatus and really arrange for not allowing this virus to sort of start replicating and cause problems. It identifies these viruses very quickly and really puts them back in sort of dormancy. Now, that's the main sort of form, but there are some data really, and I'll show those to you, that antibodies, particular BK specific antibodies, can also be quite helpful in controlling this virus. So it seems like most infections, the immune system is complex. There are multiple arms. Some have more sort of specific roles in controlling specific pathogens, but for the majority, it's really a combination of the immune system as a whole in controlling certain types of infections. But what we know is BK really only becomes relevant in the setting of immunosuppression, right? So we can reactivate and start multiplying, infecting other cells, and then sort of initiating that whole cascade of disease. Now, we know this obviously from how it's been described and what we find in our patients, our transplant patients, but also, there are some data now showing that the intensity of immunosuppression, right? Like you were saying earlier, not every transplant recipient is obviously the same in terms of their own sort of genetic component, but even also their immunosuppressive regimen. So the intensity of immunosuppression, sometimes the type of immunosuppression, really is correlated with a higher risk of progression of BK from just, minor shedding of the virus to more relevant infection and then to disease. And then, sometimes obviously even losing the graft, which is really what's most worrisome. So that's obviously the main component here, immunosuppression. Now, what's also interesting, and we'll talk a little bit more about this later in terms of major risk factors for BK disease after kidney transplant, is that, we talked so far about primary infections, right? Like when you initially get infected. Now, obviously, most cases are really, we catch as kids and it's dormant, in the body and then can reactivate after transplant. However, there is a small number of people who never had BK and got a transplant, got an organ with BK. So that can be another venue for transmission. It's sort of like it's also primary infection, I suppose, because the recipient is again being primarily infected, but it's a different scenario because it's coming from inside, it's coming from that allograft. So people say sometimes non-primary infection, but it really is sort of, very similar. It's a new virus for that person. And many of you will be familiar. In CMV, we have that concept, right? A donor who's positive and a recipient who's negative, that D plus R minus is a high risk for CMV. And there are a lot of sort of concerns that that D plus R minus BK is also a high risk for our transplant recipients. The numbers are not the same because if you think about it, the majority of people are already infected with BK is really a small number that has this problem, but it can be still quite significant. So, how often do we see BK in the transplant world, in particular after kidney transplant, right? How often does this impact our kidney transplant recipients? So it turns out, it's quite common, right? So about 30 to 40% of kidney transplant recipients eventually developed some level of BK in their blood, whether it's, a tiny amount or a large amount, whether it's a transient or very brief period or a more prolonged period. Obviously, those are all variations and depend on other things, but it is incredibly common in kidney transplant recipients. And the issue is that, there's a sort of this 5 to 10% who eventually do develop sort of more kidney involvement and more disease from BK. And obviously, that's the part that we really worry about. But what the good news is that, even of those 40% of patients who developed BK viremia or virus in the blood, most patients don't have significant complications. They don't lose their transplant. And in fact, most patients clear the virus, either spontaneously or with careful management of their immunosuppression. Obviously, we'll talk more about that. But the issue is that if it's not identified or for some reason you can't clear the virus over a long period of time, there is a serious risk that it can damage the kidney allograft. And that's what we term BK nephropathy, right? And we'll talk a little bit more about BK nephropathy in the next several slides, because that's obviously the big issue. Now, there's also obviously, these are the direct effects of BK, right, causing direct damage to the kidney allograft. Now, the other concern is, whether it's because of the virus itself or because of the management of the infection by reducing immunosuppression, there is some concern, or there are some data showing that the incidence of allograft failure due to rejection can also increase, right? So those are sort of the downstream cascading impacts of BK, which is a real problem. And whether it's like 15 to 50%, I think those numbers are a little inflated. We certainly don't see that much allograft failure, but it's sort of, it is sort of a serious risk. So what is BK nephropathy, right? So it's defined as a progressive kidney dysfunction resulting in either an asymptomatic, acute, or slowly progressive rise in the serum creatinine due to the BK invasion and destruction of cells, and can progress to kidney allograft loss, right? So what's interesting is, or maybe not surprising, I should say, it really occurs predominantly when BK occurs. It really impacts the kidney allograft, the native kidneys, whether those are partially functioning or wholly sort of damaged already and non-functional, those are generally spared. Um, and we'll talk a little bit about that later, but it's certainly an interesting finding. But as the viral replication persists and sometimes maybe worsens, right, it causes injury to the renal tubular epithelial cells, which again are incredibly important in managing electrolytes and water balance, which unfortunately then starts being destroyed, directly resulting in kidney function. And this is direct viral replication and destruction of the renal tubules. Then subsequently develops inflammation and fibrosis, which is basically scarring of the tissue. And it's not just the renal tubular epithelium, it's the glomeruli, right? Sort of the active sort of part that really does the major filtration in the kidneys. Those start getting damaged and fibrosed. That then, unfortunately, then leads to sort of this negative feedback and sort of a self sort of fulfilling problem that then leads to further injury of the tubules, or the glomeruli, and then necrosis and nephron loss. And that can sort of, eventually run its full course and basically destroy the whole allograft, right? And again, this issue of nephropathy and rejection, it seems like there's a bidirectional sort of relationship between the two. In some ways, rejection can sometimes lead to BK replication and then destruction. And again, it's sort of maybe poorly understood triggers for why BK can reactivate and start causing problems. But then BK nephropathy itself can be a trigger for rejection. And sometimes it's because of the treatment of BK nephropathy, right? If you're reducing immunosuppression, you're certainly increasing the risk of rejection. But there's something also about the inflammation and all the sort of like the cytokines released and the damage that's being done to the kidneys that can then subsequently elicit rejection. So, I don't fully understand all of that. I mean, I think that that is certainly something that's seen and of concern for sure. All right, so what are some of the risk factors for BK nephropathy? So we talked about the major one, right? The intensity of immunosuppression, in particular, medications that impact cellular immunity. So think about kidney transplant recipients, right? They receive thymoglobulin, which already knocks out, a big component of their T cells, right? So that automatically puts a kidney transplant at risk for BK reactivation. There are real good reasons why a kidney transplant may receive thymoglobulin, but this is certainly one of the trade-offs, the risk of BK reactivation and replication. And this is a dominant risk factor. But then there are other medications, right? So that we'll talk a little bit more about sort of calcineurin inhibitors for sure, and mycophenolate. Or sort of the anti-metabolites, all of those have been implicated with the risk of BK reactivation. But there isn't a specific immunosuppressive drug that's definitively associated. We know that calcineurin inhibitors and tacrolimus certainly has been described as a medication that has an association and an increased relative risk of PK replication. Whereas, for example, mTOR inhibitors, right, the main one being sirolimus or everolimus, for example, they actually may be associated with a lower risk for BK replication. I try to look at some information on belatacept, right, or Bella, which many patients are on and really love it. I generally have a bias against that drug, but that's because I'm an infectious disease drug physician, and I see a lot of CMV with Bella. But it turns out that Bella may actually be really great for BK. There are some studies showing that there's lower risks of BK replication with belatacept. Again, I don't know sort of why the mechanism would be such, especially because we do see viral infections sort of overall increasing with belatacept. Whether it's because maybe the patient's no longer on tacrolimus, I don't know. But there are some data there that maybe it's sort of BK sparing. Um, the other risk factor that I think is really relevant, and we don't talk a lot about it, is again this sort of high risk serostatus, right? So if you have a donor with BK, and you have a recipient without BK, are you at greater risk? And it turns out that yes, you are. The good news is that this is not a large group of people because most people have BK, but it's certainly an important element here. What's also interesting about this is it turns out, right, BK is not just one virus. There are actually four main serotypes or genotypes or strains of the virus. So if the donor has type A, right, they all have their little names. It's not that, but just for example, if donor has type A and the recipient has type D, maybe the viruses are different enough that your immunity to type D is great, but not to necessarily to type A. So you might get, you might develop some problems from the donor's BK. I think that's a new area of investigation. I don't think that there's a lot of data on that. I think some of the what we have is sort of circumstantial based on antibodies, and I'll show a little bit more about that. But there are some interesting aspects of the different kinds of BK and the donor and the recipient sort of interplay. The other interesting fact is that if they're at the time of organ donation, whether living or deceased, and probably more likely deceased, if they have BK in their urine, like this term viruria, that actually puts the recipient at a greater risk. We don't clinically measure those things because it's just sometimes not feasible to do so, or at least we haven't figured out a way to sort of efficiently do this. But if that is the case under our research, that might be a greater risk for BK nephropathy and sort of BK replication and complications. Um, but again, that's sort of an interesting thing. And then, these last two factors, right? The donor and recipient serostatus, maybe the type of of strain that of BK, and then the donor sort of, actively sort of releasing virus in the urine, which suggests that there's virus in the tubule cells. Talk about sort of how the donor may be a really important source of transmission, maybe even more than the serostatus sort of numbers should indicate. So it's certainly going to be an important area of research in the future, and I see some papers on that. I don't think that there's conclusive evidence to sort of be practice changing right now, but this is going to be really interesting going forward. All right. This is the issue about the serotype. So I highlighted this paper last year when I was at ATC in talking about sort of top viral papers in transplant. I had the honor of presenting that. So this is one of them that I presented because I thought it was pretty interesting. So this was in Switzerland, one of the Swiss transplant cohorts. They have a nationwide database. And, they were able to get a project going where they analyze prospectively plasma from almost 400 blood donors and 428 kidney transplant recipients. And in those 428 kidney transplant recipients, 134 cases had BK viremia or DNAemia, right? There was virus replicating in their blood subsequently. And then there's 294 controls, meaning they never had any problems with BK. And they were actively measuring and analyzing the four types of BK, ST1, 2, 3, and 4. So what was interesting, and this is just in a nutshell because we don't really have a lot of time to talk about this, but what was interesting is that the kidney transplant controls, meaning the recipients who never had any problems with BK, had at time of transplantation significantly higher ST1 neutralizing activity. Turns out that ST1 might be the most important and certainly most prevalent BK virus. So if the controls had antibodies with neutralizing activity against that particular serotype, they actually were in better shape than the others. Um, though the kidney transplant cases, the ones that did develop BK viremia, over time they did see increased anti-ST1 antibody levels. So you can see here sort of these are the cases, right? So the patients with BK, over time they did have increasing levels of antibodies, whereas sort of these were the cases in dark green. They already had much more antibody sort of activity and levels than the controls. All of that is to say is, although a lot of studies have focused on T cell activity and ways to sort of control the virus through T cells, um, there is an emerging consensus that, antibodies may also be pretty important as well. And whether you do this, sort of uniquely, whether you just give antibodies or you just give T cells, or perhaps you give like sort of a combination therapy, this is going to be really exciting stuff in the next sort of 5 years or so. Anyways, so this is sort of hypothesis generating. And certainly now you are seeing sort of some monoclonal antibodies being developed for BK as well. All right, so we'll talk more about that later. But that's sort of just sort of in a nutshell, sort of, antibody levels really do matter as well. So, all right, so what is the pathogenesis of BK nephropathy, right? So, initially, what the first step is once the virus reactivates, it starts being released in the urine, right? Because it's the renal tubular cells, there's virus being released, and down the urine they go. That's the earliest manifestation. That's how you catch BK sort of as in its early stages. It's only really detected by screening, right? Obviously, you have to sort of be screening your patients for BK in the urine to detect it. And it's enormously common. By in the first year following kidney transplant, about a quarter to a half of patients will have evidence of BK being released in the urine, sort of this BK viruria. The vast majority are, again, asymptomatic. You don't know that you have that. Even the urine doesn't really look any different, whether it's sort of visually or even when you send a urinalysis or a urine microscopy. All this is indicating is local sporadic replication. Now, there are these cells called the decoy cells, which I quite honestly haven't seen in a while, but it's sort of something like of sort of um, a more sort of, a few decades ago was being used to sort of see, was there sort of maybe, a lot of BK and, this is sort of pre-PCR type measurements. But again, even if you have decoy cells, this does not usually progress in most people. Now, the issue about this sort of so-called viruria, right? So virus in the urine, it's a sensitive marker for sort of BK detection and potentially even sort of are they at risk for progression of disease, right? And we'll talk about the next stages in the next several slides. But the issue is always in medicine and certainly in science in general, right? Is it specific enough, right? Sort of, is this sort of enough to say the patient has BK nephropathy or the patient is going to get sick? And the answer is no. There's lots of people with BK in the urine, and many of them don't get sick at all. So while this could be a marker or something to trigger monitoring, in and of itself, it's not, it does not correlate with disease. Um, and like I said before, even in non-immunocompromised patients like older adults, pregnant women, it turns out, they and diabetics, I didn't have that here, they can release BK in their urine, and again, they don't have get sick from this. There's no clinical consequence to it. All right. I wanted to see, what a decoy cell was. It's been many years since medical school. This is a high resolution, and I'm sorry that it's sort of blown up too much and you can't really see well. But this is a urine epithelial cell that gets released in the urine, and you can spin down urine and put it under a microscope, and you see the kinds of cells that are there, right? So this is what you may find. And if you find this type of thing, you're going to call it decoy cell. What's characteristic about it is the nuclei, the nucleus, sort of this big circle in the middle, right, which generally contains the DNA material for the cell. Well, decoy cells will have an enlarged nucleus. And it's round and it's smooth, so it's a little bit different than the normal nuclei of non-infected epithelial cells. This is very characteristic of an infection. It also has sort of this intranuclear inclusion. You see, like it's not uniformly stained dark blue. You sort of have this what they're calling ground glass. You almost have the sense that you can see through it, but in a ground glass sort of opaque way. And then you have this rim, right, of condensed chromatin, which is sort of an important protein in the DNA coiling. So that's what a decoy cell is. Back in the day, we used to spin a lot of urine and look for these things as an indication of BK. Don't really do that anymore because we have the PCR test. All right. So the next stages in terms of BK nephropathy and sort of eventually developing BK nephropathy, right? So, if the infection is intense enough, it's obviously being BK is being released in the urine. But then, after a certain threshold, you start seeing BK in the bloodstream, which is also known as viremia, right? That's the medical term for a virus in the bloodstream. And the general trend sort of time frame is a few weeks to a few early, sort of a month or two, in terms of the progression of disease. And it really occurs most frequently in high urine viral loads. And I have one slide about what constitutes a high viral load. It's sort of in the millions. And then sustained replication. It's not only high viral loads in the urine, but really over weeks to months, right? It's sort of one or two may raise a flag, but may not necessarily be of high concern, as opposed to someone who has, 4 weeks, 5 weeks of this, right? And it's not going away. Um, and in terms of, again, of the time frame, when do patients most commonly sort of develop the BK viremia? It's really, in the first year, first 6 months after transplant, right? And again, that's another indication of the intensity of immunosuppression, right? That's when transplant recipients are most intensely immunosuppressed for 6 months to a year. And that's when you see BK viremia more often. Again, just like viruria, patients are asymptomatic. They don't know that there's virus replicating in their bloodstream or being released in the bloodstream. There's nothing indicating any symptoms. But, unlike viruria, viremia has a greater predictive value. And that's why it's important. And that's why most transplant programs really sort of monitor a lot of BK in the bloodstream because this is a more useful test to sort of monitor and see if someone is at risk for BK nephropathy or not. And in a medical parlance, it has a greater predictive value or positive predictive value, meaning if you find BK in the bloodstream and it's at a high and persistent level, that's you're a high risk of BK nephropathy. And again, you see here it's about 40 to 65% in patients with sustained and high viremia. So, if you find viremia, and obviously we'll talk more about this and what to do, but just in a nutshell, if your transplant physician finds BK viremia, that's usually the trigger to start considering reducing immunosuppression to the degree that it can be safely done. Maybe not one read, maybe not two reads. It really depends on the level. But you have enough positive PCRs or it's high enough, that's really when the discussion will take place, and you might get a call from your transplant provider. Hey, it's time, to do something about immunosuppression. Um, and the reason why, this is important is because time is of the essence, right? In some ways, the longer the viremia persists, the longer sort of that viral replication and infection is taking place in the kidney cells. And obviously, the more likelihood it is to have serious kidney damage, right, over time. So that's why all of this is really important to be monitoring and acting on within a reasonable time. So I have this because, kidney biopsies are always fascinating to me. I'm certainly not great at reading them anymore. I was at some point in medical school, but I know enough. But the kidney biopsy is really the gold standard to sort of establish the diagnosis of BK nephropathy, and distinguish it from rejection, which turns out it's a really, really hard thing to do. And you really rely on your pathologist to really read. But obviously, the identification of virus in the kidney cells is really sort of the distinguishing factor, right? So, bear with me here. So, panels A and B, these are sort of, really high magnification of kidney cells. And here you're going to see this is a glomerulus, right? This is sort of the unit of the kidney, where blood is being filtered out and sort of urine or the toxins and other things are being separated into the urine and the rest of the blood stays back to the circulation, right? This is a glomerulus. So the arrows are showing here stain for the virus. So there are certain stains that the pathologist can add to the biopsy that will directly identify BK. So here's one right here. Sort of this cell is infected with BK. Here is another one, sort of, in the glomerulus, sort of some of these sort of larger dark cells, they are infected with BK. And these are sort of higher magnification over here, and you can see the arrows are all pointing to cells that are infected with BK. That's the distinction, that you're not going to see in rejection, right? Rejection can be due to multiple reasons, right? But it's usually your own cells being destroyed by the immune system. And there's BK normally doesn't have a role in that. So you're not going to find BK in these episodes of just straight out acute cellular rejection or antibody mediated rejection. Whereas obviously in BK nephropathy, you're going to see that. And, I don't know enough, but this seems that there's sort of greater degree of inflammation in these cells. I can't tell you if there's more fibrosis here or not. They're not necessarily talking about here that this is an advanced stage of BK nephropathy, but there's probably some degree of dysfunction here in the glomerulus that is implicated by the BK infected cells. Okay. But there are some classifications of PK nephropathy. This is sort of one of the Banff criteria, right? People really got together and tried to classify this. One, how to distinguish it from rejection, which most of the time can be straightforward, but there are times when this is not straightforward. And then the severity of the nephropathy, right? Um, sort of there, there are three levels of severity here, which is polyomavirus nephropathy class 1, which is generally mild, PVN class 2, which is moderate, and PVN class 3, which is much more severe, as you can imagine, which is characterized by high viral loads, which is this PVL viral load, and then this CI score, which is interstitial fibrosis. And this is where the pathologist is really looking at, where how much of what they're seeing in terms of all the glomeruli, in the biopsy, how much of it is fibrose. If it's less than 5%, it's pretty mild. And here you can see, the staging, whereas greater than 50% of what they're seeing in the kidney cells is fibrose. As you can imagine, that's pretty severe. 50% of the kidney is already pretty destroyed and completely sort of fibrosed at this point, right? So when you combine higher viral loads with, a lot of fibrosis, that's when you have sort of really severe PK nephropathy. These are the patients that eventually sort of, you don't recover, right? The sort of you lose your graft, unfortunately, in these scenarios where, from what I certainly you can imagine sort of less severe disease, there's a good chance of catching early and reversing some of the damage, where here it really depends on certain characteristics and how it's managed and how lucky you are in terms of clearing the virus or not, right? So this is sort of how, in a nutshell, the classification of PK nephropathy. We talked a little bit about this in terms of the timeline. It generally is a major complication in the first year after transplant, but that's not all. It certainly can occur years after transplantation. I certainly have seen my transplant nephrology colleagues having to deal with this many years after. You can imagine there's a number of reasons why it may happen later. For example, right, one obvious one, if someone is treated for rejection, say 3 years after their transplant, they are now that risk resets, right? They are now at risk for BK reactivation and complications due to that more intensified treatment for rejection. But there are other things too that can trigger. It's not clear what those are, whether it's co-infections or maybe it's just age, right? As someone, sort of they're getting older. Is this now a trigger for BK reactivation or not? But that's sort of, the timeline. And I have this. So it turns out that actually, there are now the second international guidelines for management of BK in transplant recipients was released earlier last year. So I think it's almost a year old now. And, just like the CMV guidelines, sort of around 50 to 80 experts around the world got together and really sort of went over the whole topic, right? Sort of from risk factors, pathogenesis, timeline, biopsy, all the nuances of the risks for BK and so forth, and then sort of management and sort of understanding complications, right? So it's a beautifully written document. It really has a lot of insights. But for the purposes of this lecture, I'm including one of their main figures here, which they try to put all of BK in sort of one sort of graph, for us to understand sort of the complexities of BK. So just to understand sort of, the phases, right, of PK in a natural history, right, in someone who is sort of well managed, or in sometimes the majority of cases, you're going to have that initial phase where, BK rises, right? So let's go over DNA urea or viruria, right? You have the decoy cells, which I think are going to mimic the BK in the urine. It can rise, it kind of peaks at some point, and then it drops, right? That's obviously goes without saying. That's the natural sort of life. Who knows how long this period is? It could be a few days, a few weeks, to many months, sometimes years, right? But we know that obviously this precedes viremia, right? So we talked about this many times. If you have virus in the bloodstream, you almost certainly have virus in the urine as well. And you may have decoy cells. Now, if you have, right, already virus being released in the urine, in most people, you may have sort of now the beginnings of antibodies being sort of, released to try to detect that. How well this is going to go depends on your level of immunosuppression, right? But say someone who's not immunosuppressed, right? They're going to have robust antibodies being released to control the infection. In someone who's heavily immunocompromised, this curve may be much lower, right? And briefer, and inadequate, right? And then at some point later in the stage of the infection, well into the viremia phase, you may have some T cells finally kicking in that are very specific to BK and are now part of the sort of attempt to control the virus back into the cells once more, right? And as you can imagine, just like antibodies, this is going to be heavily dependent on the individual and their immune status, right? Could be adequate, could be inadequate, could be brief, could be prolonged and effective, and so forth, right? So this allograft directed immune response is sort of what most people worry about, sort of, could this lead to rejection or not? But the other interesting thing that we didn't talk about this, and I think it goes back to the interaction between the donor and the recipient, right? As I think I've said this before to many of you, but it's important to say it again. A transplanted organ, whether it's the kidney, pancreas, liver, kidney, liver, heart, or lungs, or anything else, it's immunologically distinct from the recipient's tissue and immune system, right? That goes without saying. Obviously, it is. It's different. It comes from a different person. But the recipient's ability, immune system's ability to fight infections in that allograft is, even if you had sort of really strong T cells and really robust antibodies, the ability of that recipient's immune system to go into the transplant allograft and fight off the infection is reduced. It's not the same as in just the original parts, right? And it has to do with the interaction between the immune system and a number of cell receptors in the recipient. So it's just not as effective. And I think what this part is saying is, even if you have this immune response, you only really have an effective allograft immune response really late in the stage, right? And this is what may set up sort of ongoing replication in the allograft and kidney damage because it really is a delayed effect, okay? Or just efficacy. It's just the immune system doesn't do as good of a job. Um, this is sort of obviously the general net state of immunosuppression, right? Whether it's because of what the doctors are doing or even the effects of the virus on the immune system, not very well known. And I think, this is just to illustrate, at times when you do start having severe kidney damage, right, your serum creatinine is going to go up. These are sort of the pathologies in the allograft. It goes from mild inflammation to much more severe inflammation and maybe even the risk of acute rejection. Okay. This is sort of what's happening inside the kidney and in terms of pathology and histology. All right. So it's a fascinating sort of type figure, that just gives you sort of an overview of BK. All right. Now, in non-kidney transplant recipients, I know I was asked that question by Jen, what is BK significant at all? Is this exclusive to kidney transplants? By and large, this is really, vastly more important in kidney transplant recipients than in other immunocompromised populations. But the truth is that we do see BK problems in non-kidney transplant recipients. So what's interesting about it is that we do see BK viruria and sometimes low-level viremia in all sorts of transplant recipients. It's one of those things like if you look for it, you're going to find, and you can see here up to a third of patients, non-kidney transplant recipients will have BK viruria or viremia. But it's generally much lower intensity and much briefer. than in kidney transplant recipients. And BK nephropathy can occur. We've seen a couple cases in lung transplant recipients. So, for example, Jen, I don't know if you know this, but Jeff Dube, Dr. Dube, is one of our major experts in BK. And he is often the one called by like our lung transplant recipients who, when they see kidney dysfunction in their patients, ask for his counsel on managing BK. He is actually a really important figure in BK, in particular in non-kidney transplant recipients. Obviously, he knows all about kidney transplant BK nephropathy, but he also knows a lot about the other populations as well. Now, one thing that's really interesting, and we see this, me and my team see this a lot at Columbia, is BK-related hemorrhagic cystitis. So, obviously, hemorrhagic meaning bloody, cystitis means bladder, inflammation in the bladder. What this means is actually BK causing direct damage to the bladder cells, not just, down the tubules, but now it's infecting and causing a lot of damage in the bladder. And unlike the other stuff, this is you're really symptomatic from it. Urine can be really painful and really bloody, which is obviously always alarming. In fact, actually, we see quite a lot in our stem cell transplant recipients. They can also get BK replication, during their sort of pre-engraftment period, and this is the main manifestation. Why is this big hemorrhagic cystitis in those patients? And for example, why don't kidney transplant recipients get this? I don't know. But it's quite unique, and we see this a lot in our stem cell transplant patients. BK is not the only virus. Adenovirus can do that too, but we certainly see a lot of BK. But what I meant here in this bullet is that, the issue about bloody urination is you can have clots forming and then you can have obstruction, because the clot can just stick there to the urethra or the ureter, and now urine is all backed up, which can be not only painful but damaging to the bladder and the kidneys. So, we don't need to spend a lot of time on this, but it's sort of quite interesting that BK has different manifestations in other patients. All right, so how do we monitor for BK? Obviously, that's an important question, right? If we know all about this, you know, how do we monitor it and what is it that we can do to prevent BK from causing problems, right? So a couple of tests are available. One of the things that it's really important to talk about, because this is undoubtedly is going to generate a question, right? If the donor recipient sort of combination matters, do we check for antibodies and do we know who has it and who doesn't? The problem with antibody testing, which would be the way to know, it's or serology, right? That's the medical term for that, is it's not standardized, unfortunately. So, whether Quest, LabCorp, or in-house tests, they don't give the same information. And in fact, because you have four serotypes of BK, different serology tests are really going to be biased towards maybe one or two serotypes and not give you the full picture, or uh, um, and not pick up, so you can have false negative results, right? So that's obviously not great. Might give a false sense of security or even a false sense of alarm, if you don't really have a good idea of who's infected and who's not infected. So serology is something that might happen in the future, but it's certainly not sort of something that we can easily order, for example, in our EMR. So how do we really monitor for BK is really through PCR testing, right? So we talked about this already a few times. You can detect BK in the urine, also known as viruria. A lot of people have it. And it's kind of a cheap, quick, and non-invasive screening, right? I'd rather give a sample of urine than give a sample of blood. I mean, I think many of you will share that. It's much easier and less painful. But we talked about some of the limitations, right? It's generally not that specific. So really, the gold standard of monitoring BK is really blood PCR to detect viremia. And there are a number of protocols in place, but I think most centers have converged on what's generally recommended by the international guidelines, which is, you monitor this once a month for the first 6 to 9 months after transplant or after treatment of rejection. And then after that, if all is well, it's negative, you do every 3 months until 2 years post-transplant. In kids, because they are higher risk of developing BK or acquiring the BK, this extends to 3 years post-kidney transplant in the pediatric population. Again, if there's allograft dysfunction or rejection, you start monitoring again. Okay. Only because it can happen, it's common, and it's important to detect so you can manage it appropriately. Um, One caveat on plasma PCRs, I think I talked about this about CMV as well. Whereas, if you go to Quest and you get a creatinine, and then you come to Columbia and you get a creatinine, those results are quite interchangeable and reliable, right? If you take one sample and take to both labs, they're going to give you pretty much the same result. They're standardized. Um, PCRs are not, unfortunately, and there are a number of factors that go into whether it's the machine that measures it, the components that they're using. There's a number of factors so that you can take the same sample to Quest and Columbia, and you're going to get different PCR results, sometimes quite significantly. So, if for you kidney transplant recipients, when you're following these sort of protocols, I know that life gets in the way and there's additional other important reasons why you would not go to the same lab every time. I totally get it, and it's totally fine. But, if there's an ability to go to the same lab for those 6 to 9 months or 2 years, it's always better. Also, the important thing to understand is, also don't be alarmed, right? Like if you go to Quest and you get, a value, say, of 1,000, right? And then the following day you happen to come down to Columbia and you're seeing Dr. Doob or Dr. Chang, and they also get a BK plasma PCR and it's now, 4,000, well, it could be that the virus is changing, but more likely it's just because the PCR was measured at different labs. Okay, so this is important. Now, we don't biopsy patients to monitor for BK. That's obviously a highly invasive, procedure, but it's really only there to confirm the BK pathology, or in someone who's a high risk for rejection. I'm going to go over an algorithm that's generally sort of outline how to manage this, and I'll show you where a biopsy sort of features into that algorithm. Not every patient with BK needs a biopsy, so that's also good to know. All right. So what happens if BK is detected, right? I think many of you have experienced this. So generally, that triggers a more frequent monitoring instead of once a month. Many centers go every 2 weeks, or at least many providers will do that. So that's one thing, and you monitor it until it gets cleared, or something changes, right? Whether you go on treatment, or obviously changing immunosuppression, or it clears. Um, but obviously the PCR is going to give you sort of some significance, right? Obviously the PCR is going to give you numbers and quantification. And the significance of the BK generally it's thought of, whether it's greater than 10,000 copies per ml in one or two measurements, or if you have 1,000 to 10,000 copies per ml at least twice over 2 weeks apart. So either really intense viral load or a persistent viral load. Those are two significant sort of measurements or sort of findings when it comes to BK, and that's really important to sort of understand, right? And if it is found to be significant, right? Every patient is going to be different. That's when you start sort of doing the things that we do to control BK, which largely is reduction in immunosuppression. And we'll talk about that. The issue with BK, as many of you have come to understand, right? But it's worth repeating. There are no approved antiviral therapies for BK, which is a huge problem, you know. And in some ways, right, it limits what I, as an infectious disease doctor, can do for my transplant patients with BK because I'm pretty much limited to just recommending for the time being, reduction in immunosuppression. Now, there are some exciting things up the pipeline that we can talk about, but for now, there is nothing approved to treat BK. So, and the goal of monitoring, as one would imagine, right? It's to obviously, try to avoid rejection and allograft loss and to decrease immunosuppression is really to allow the immune system to control the virus. We'll talk more about that. So Dr. Jay Chang, who maybe some of you will know, he's another transplant nephrologist at our center. He works with Dr. Dube and Dr. Mohan and Dr. Cohen. He's part of the group. So he's taken an interest in BK. He's given a couple of presentations. I asked him for, do you have any slides that I can use, for the transplant journey and for my presentation tonight? So he gave me a couple, and I give him due credit over there, courtesy of Dr. Cheng. So this is one of his slides reviewing this particular study from 2008 in the Journal of Transplantation, talking about using reduction in immunosuppression in controlling BK, right? Because if that's what we have, how do we know how good it is? So this was a particular protocol in kidney transplant recipients who had BKD anemia. And they were looking at sort of, the impact of reducing immunosuppression, whether it was the mycophenolate dose or the tacrolimus dose or the tacrolimus level, and, or even the prednisone levels. And in that population of 24 patients, looking at what happened to their BK, you can see that, in terms of after reducing immunosuppression, this is the first 15 to 30 days, the first 60 days, 90 days, 120, 150, 180 days. You can see the levels of BK, really nicely going down, right? I mean, this is actually pretty high levels, right? 400,000 copies per ml. And you can see that after starting to reduce many of these components, you can see that it went down by a half, and then by another half, then by another half, and then sort of, by last to follow up, which is, about 6 months, right? 180 days. It was down to 50. So I think the important findings here is that reduction in immunosuppression does work in reducing viremia, but it takes a while. It takes months for that reduction to take place. So the mean follow-up period was 44 months of post-transplantation, and the mean doses of mycophenolate and tacrolimus level were almost sort of, around 40%, right? So pretty drastic reductions in immunosuppression. I don't think that in this particular protocol they had both, it was either one or the other. But, regardless, that reduction in immunosuppression significantly correlated with a decline in BK, DNAemia or viremia, however you call it. And there were good allograft long-term outcomes. I guess they didn't include creatinine here in this table, but I think in the study overall, most patients had their grafts saved and in good function. Another study looking at sort of, all right, so we know that sort of reduction in immunosuppression works, but there are some other investigational sort of interventions, right? So we talked about how mTOR inhibitors like sirolimus, patients have a lower risk of BK replication. So what if we switched one of the immunosuppressive regimens to an mTOR inhibitor? Or how about IVIG, right? As you know, IVIG is pooled immunoglobulins from a number of healthy donors, many of which undoubtedly have BK antibodies, right? So now you're getting sort of a fresh supply of BK antibodies. We'll talk a little bit more about IVIG, but that would be the idea here. So in blue, it's sort of the mTOR plus IVIG protocol, and in red is the standard reduction in immunosuppression. And what's really interesting is that, reduction in immunosuppression, not just sort of a lateral move, right, between, say, tacrolimus to sirolimus, it didn't work as well as just straight up reducing immunosuppression. This is a study from 2022, which was really telling, right? I mean, I think that, there are a lot of ideas out there on how to control BK. Some may be effective, but others may not, and I think that that's the dilemma that most transplant providers are dealing with. On paper, it sounds like a good idea, but in clinical trials, doesn't always pan out. And many of you have seen that, right, in numerous situations. But anyways, I think reduction in immunosuppression over and over again gets shown that it's sort of so far, in the absence of an antiviral medication, it really is the most effective way to control BK viremia and hence sort of prevent BK nephropathy. So generally, the what Dr. Chang and my transplant nephrologist at Columbia advocate is a stepwise approach, right? You generally, as with most infections, generally reduce the dose of the anti-metabolite, which is mycophenolate, generally by half, and continue everything else, right? Whether it's the tacrolimus or prednisone or both, and then you monitor the creatinine and BK PCR levels from the same laboratory, right? You don't want this interassay variability. If unfortunately after a few weeks there is no improvement in the viral load, you then completely stop the mycophenolate. That's what the Columbia protocol is, and many centers do that. And again, you monitor the BK. If again that there's no improvement, then now you start sort of reducing the dose of the tacrolimus through the troughs, right? Like your trough goals get reduced. And I think once you're down to this level, I mean, generally you do see an improvement in BK viremia, right? We'll talk about the implications of sort of this, protocol. Obviously, there are a few, but the important thing is that this is slow, methodical, and may take weeks to months. This is not something that gets resolved quickly in some patients. Um, this kind of mimics a lot what the second international guidelines have generally sort of recommended in terms of how to overall think of BK and how to monitor and how to treat it, right? So bear with me here. So the general protocol is, you get a kidney transplant and then post-transplant you initiate the sort of screening protocol that we talked about. Monthly PCRs in the blood until month 9, and then every 3 months until 2 years. But in the pediatric population, is 3 years. Or if you reinitiate this protocol if there's allograft dysfunction, meaning your creatinine is rising and your transplant nephrologist doesn't know why. Or if there are times when the allograft biopsy is performed, and there might be a little bit of a concern for BK. They're not sure. They don't find BK, but maybe some of the features are concerning. You're going to start monitoring for BK. All right. If you find BK in the virus, right? Now, the fork in the road is your immunological risk of rejection, okay? And that I don't necessarily know how one assesses, but everybody has a different risk, right? And sometimes you have ABO incompatibles, right? Which are going to put someone at a high risk, or they have a lot of DSA and sort of there's general sense of who's at risk for rejection or not. If someone is at risk for rejection, this is when generally a biopsy is obtained to sort of try to interpret, right? Are we seeing, is this because there's BK or is this because of rejection? And you really want to distinguish those two because the treatment is going to be diametrically the opposite, right? If you have rejection, you intensify immunosuppression. If you don't have rejection, but you have BK, then you reduce immunosuppression, right? So you really need to know what you're dealing with before you start mucking around with immunosuppressive therapy. But that's in the context of someone who is at high risk for rejection. If they're not, and there's really nothing else that's sort of suggesting to the transplant nephrologist that there is rejection, that what you're seeing really is related to the BK, you can proceed directly to just reducing immunosuppression in the ways that were outlined by Dr. Chang. Um, and if it works, great, you've resolved it. If it doesn't work and the serum creatinine is increasing, this is where you may have to further reduce immunosuppression, right? Until you get to this resolved nephropathy. Obviously, these are sort of difficult situations right here. It may go back to getting a biopsy to really make sure that, this situation hasn't reverted or become complicated by rejection. You can imagine all sorts of permutations here, right? But that's sort of in a nutshell how one would sort of mentally think about how to manage BK. All right. Now, the second international consensus guidelines put this really helpful sort of one, slide. It's beautiful. It's written by my colleague, so I just want to give him sort of a shout out. Dr. Cotton, Nassim Kamar, who works in France, for example, they were the lead authors in this sort of set of guidelines. What is important here is that they outline some of the risk factors. They obviously outline the screening. They really talk about reduction in immunosuppression as the primary method of controlling BK. They don't really put a lot of stock in things like IVIG, cidofovir, leflutamide. Certainly, the data for things like fluoroquinolones, like levofloxacin, have really shown strongly that they don't have any activity against BK. So they don't really recommend any of those other sort of interventions other than just reduction in immunosuppression. And obviously they understand, unfortunately, right? That's where we are, but that's really where the studies are suggesting of highest impact and really important to consider as opposed to try something that may not work, and at the end of that treatment you are worse off, right? Now with more advanced BK nephropathy. Um, they also then talk about consider retransplant, right? If BK nephropathy is leading to real severe allograft dysfunction, then retransplantation might be the way to go, right? So that's obviously ultimately the what we don't want to see, but it does happen. Um, so one thing about IVIG, because this is something that will be talked a lot, I guess as a concept, right? Giving immune sort of, antibodies, maybe not immunoglobulins, right? Because sort of the proof of effectiveness has been very limited. But then you have all of this data. This was my earlier slide talking about how neutralizing antibodies do play a role. So how do we put these together? It might be that maybe IVIG is not the right drug. It doesn't have the right types of antibodies in sufficient quantities to really do this. And remember, we talked about this COVID, right? Not every monoclonal antibody product, really was sort of important. And certainly is sort of IVIG, versus sort of the right monoclonal antibody product really sort of made a big difference, right? And the reason why sort of the community is excited is there are some clinical trials about sort of really potent antibody neutralizing products against all serotypes of BK. So this was, for example, one preliminary study that showed that some of these monoclonal antibodies, incredibly reduce the viral load in certain patients. I don't know if many of you remember, I showed these ad nauseum curves, right, about sort of monoclonal antibodies for COVID. It's the same concept, right? Concentrations reducing when these sort of antibodies get exposed. And now there are some clinical trials about some particular antibodies. I didn't have time to add here, but there is this sort of MU something. I don't remember now, but I was looking at it shortly before this. There are some companies now starting to sort of really push for some of these studies for monoclonal antibodies because they really show some really good impact in controlling viremia in particular. So expect to see in the coming years a lot of trials, a lot of data, and really sort of maybe some good results. As you know, monoclonal antibodies are generally very safe. They can be expensive, so you really have to think carefully about the cost versus the efficacy, but they so far can be pretty good. Now, the other sort of therapy is virus-specific T cells, right? So we talked a little bit about it before. So you can train T cells against certain viruses. We talked about CMV last time. Well, it turns out you can train T cells against BK as well. And in fact, over the last decade or so, there's been some case series and some initial trials of using virus-specific T cells against BK. The large one, and there's some reviews talking about how exciting it is, right? You take white blood cells from a donor, you introduce them to a viral antigen, and you train them to grow and sort of learn this viral antigen. You grow them, and then you give it to the recipient, and then you can sort of attack the infection, right? But in fact, there are now some studies showing that these cells can be really helpful. This was a study from, I want to say a year or two ago. I should have had the year here, but posoleucel is the product, of sort of a multivirus specific T cell. Um, The company didn't pan out, unfortunately, but this was sort of a proof of concept that they gave this product for transplant recipients with BK. In fact, there were 61 transplant recipients with BK viremia, and they treated with this T cell, which is interestingly an off-the-shelf product, meaning like you didn't have to wait to produce it. It was already ready. All you have to do is get it and infuse on the patient. They intervened over 12 weeks. It was randomized. And what it showed is one, it was extremely safe. And then it showed a reduction in the BK viral load, sometimes by over 50%, in the group that got weekly product for 3 weeks and then every 14 days for the 12 weeks. This was a less intense, the group two, and they had a less intense response. So all of that is to say, and obviously compared to the placebo, there was minimal response. So all that is to say is this product may have effectively reduced viral load of BK in these patients. Unfortunately, this is not available. It didn't go through. The company, had sort of issues with the other sort of therapies and certainly they're not sort of moving on. But as a proof of concept, there are a number of other companies and investigators really working towards virus-specific T cell as a therapy for not only BK, for a number of other infections, including CMV.
Hey, Dr. Pereira, I was going to just make a comment regarding the clinical trials. And just full disclosure, I work as a consultant for Memo, also a transplant recipient. But
Mhm.
the company Vera Therapeutics, their phase two trial was completed. They haven't made any announcement about their phase three. And then Memo is completed phase two. They're going to phase three. There's another company, AI Curus.
Uh-huh.
They're moving forward this year. And then there's another company out of Boston that Dr. Chandraker is involved with. So I just wanted to give everyone an update that there's a lot of activity and hopefully you'll have some options. So anyway,
Yeah.
thank you.
Yeah, great. Thank you, Kevin. So, even at Columbia, right, we do have one of our investigators. This is Dr. Moransky. I think I showed this photo of him for the CMV trials, but, in his trial, it also includes BK. This is Dr. Chang, who is now one of the co-investigators because he is leading sort of the BK viremia arm of the study, in identifying, recruiting, and following these patients who do get this product. And I have to say, I think they've found some really good success for BK viremia in kidney transplant recipients as well. So again, just like the antibodies, expect a lot of future studies on this because I think that this is sort of one important way to try to treat this infection and prevent its complications. So, and then last, retransplantation, right? It does happen, I don't know exactly the number of patients who lose their graft after BK and eventually get retransplanted. I didn't have time to look at that. But the good news is that if you get retransplanted, the rate of loss of a second allograft is much lower, 6 to 10% compared to the sort of other sort of, advanced BK disease. So it is an option. We do have many patients who do get second, sometimes third transplants, not all because of BK, but some are because of BK, and they do okay. There are some sort of criteria. You do have to show that, you you don't have active replication prior to transplant. This is clearly important because the last thing we want to do is you have that as a second complication, right? But the good news is that, in some ways, if you lost your allograft, immunosuppression is much reduced, so BK generally goes away. And then people are much more careful with what immunosuppressive medications they give and how they are monitoring in order to prevent this from becoming another problem. All right. I know that sort of it's already, 9:24, so this is a long talk. Jen, you had some really wonderful questions. I think I answered most of these, in terms of adjusting immunosuppression, what other organs or types of patients are impacted, if the virus becomes undetectable, the virus is not gone. It is dormant and can reactivate later, although generally less commonly, but certainly if you get treated for rejection intensely, you are at risk. Um, no clinical early warning signs other than monitoring the urine and the blood. And this is highly individualized in terms of modifying immunosuppressant, although there are general protocols. Um, In terms of BK treatment strategies, at the time being, it really is my nephrology colleagues because it is all about reducing immunosuppression, right? Hopefully, in the future, we'll have more people being able to contribute managing this complicated infection. There are a number of emerging therapies, like we talked about, in terms of T cells and monoclonal antibodies. I don't know about antivirals, but I do think every once in a while you hear about some kind of chemical that may have activity against PK. So I wouldn't be surprised if there are some in the pipeline. We talked about monitoring. We talked about thresholds. We talked about how long does it typically take, right? Weeks to months to control the virus. And once that happens, generally immunosuppression does go back to sort of more initial levels because again, right, you do want to avoid rejection, right? That's obviously the flip side of all of this. Um, BK doesn't really increase the risk of other infections. I know that you might find some literature about that, but I think it's only really advanced disease and inflammation that may do that. Otherwise, no. Again, biopsy is often necessary to distinguish viral related injury from rejection, although not everybody gets one, and you can sometimes predict who needs and who doesn't. I don't think that there's anything here about hydration, infection, stress, and other medications that can trigger BK. Although, like every virus, right, there are things that do. We just don't know enough that I can say, definitely hydration. But I think stress might be a big component. Generally, most viruses can reactivate during stress. We talked about that for CMV. I bet you something to do with BK as well. Um, no. Does having BK affect future transplant outcomes or eligibility? I think the key is if you have BK controlled, you're okay. We all have, almost all of us have BK, so it's not something that, it would be fair to preclude one from having sort of a chance at a second organ, right? I think that this is going to be a fascinating topic. There are some discussions about some who are more genetically predisposed, and I think it all boils down to the genetics of the immune system, right? The immune system is enormously complicated. Not everybody has the same level. You always hear about that person who never gets sick, gets exposed just like you, but now you're down with the flu and that person is not. And that all has to do with genetics. So it's not only from catching infections, but controlling these infections. I think that there's a big, big sort of area of investigation. I think it would be fascinating in terms of polymorphisms, who is at risk and who is not as much at risk. Now, there are cell-mediated immunity tests, right? We talked about that for CMV, where, you take blood and you can sort of see if the sort of your T cells are responding to that virus, right? So that you can do for CMV. We haven't developed one for BK. I'm sure there will be one in the pipeline because it's a very interesting sort of line of diagnostics. And then how to incorporate into this protocols will be interesting, but more than that to come. And I think that would be one area that I think sort of immunologically prone people could be distinguished. Um, there's a lot of myths about BK. BK is again transmitted through sort of fecal oral, like between kids, maybe respiratory droplets. It certainly can be transmitted through kissing, I would imagine, because again, it is sort of respiratory droplets, saliva. But there's nothing, you know, it is generally understood that most people in the house already have BK. So if a transplant recipient has BK, they're unlikely to be contagious to their loved ones. And likewise, right, if someone is sick, obviously they wouldn't be diagnosed with BK unless they're immunocompromised. This is not something to necessarily worry too much about. Okay. And I think that's it. I think I hope I covered enough about BK to at least give everybody some general idea. Um, yeah, so
Dr.
I
Pereira,
think
thank you.
somebody.
Yeah, thank you so much. If anyone has any questions, we will open up to the floor if you guys want to unmute yourselves and ask any questions that if there's anything Dr. Pereira didn't cover in the
So
webinar, guys, I'll leave you to ask any questions for him.
I do want to. It's Janet Handel. It scared the daylights out of me. So I've just, I'm 15 years out from transplant. So I was
Yeah.
Googling while you were talking. So you might just want to share with people what the likelihood is if you're many years out from transplant, the likelihood that you're going to have to be dealing with this? Because I do think, it would be helpful.
Yeah, it's the greatest risk is the first year and or after treatment of rejection. So 5 years out, 10 years out, the risk is really low. It's not zero, but it's generally low. You
Mm-hmm.
may find BK in the urine, you may find low levels of BK in the blood, but as far as that progressing to BK nephropathy is really low. So I
Okay.
know it's
Thank
sort
you.
of scary, but not really. It's good.
Thanks.
Yeah.
This was very informative, and thanks both of you for putting this together. It's really interesting.
Thank
Thanks.
you, Janet. Thank you so much.
Absolutely, Janet. Anytime. Anyone else? Any other questions,
The
comments?
time is running late.
But yeah, just
Yeah.
wanted to thank you for all that. And it was a lot, but it's very important to know how much work is being done to I love that, to make
Yeah,
it
absolutely.
better for the future.
Without a doubt. It's an enormously important virus, and I
Yeah,
think we need to sort of figure out a way to control it.
yeah. But thank you.
My pleasure.
Thanks, Donna.
I'll be signing off now, everybody.
Yeah,
Have a good night. Thank you.
of course.
Thanks, Donna.
Bye.
Yeah, thank you very much for all the information. It's very detailed. I got lost at many points, but no, this is great
Okay.
because many time, the readings you can find on Google, it's high level, doesn't go deep. And so you always question. So this is great. I think there was enough
Good.
for everybody, and even if we get lost at time, it gives us an understanding of some of the mechanism and so on. So thank you so much for going over the details and being so
Sure.
broad
Thank
in
you.
your
Thank you.
explanation.
Thank you.
Thanks, Remy.
Thank you, Jen.
So, Jen, I think I'm afraid I have to go. I'm getting some texts over here that I just have to go down and take care of the kids. In full disclosure. So, but
Thank
hopefully
you.
people can email me questions. I'm happy to answer it. And I'm glad you recorded this. And hopefully I didn't say too many wrong things.
You're in trouble.
Yeah.
And listen, if we get any extra questions,
Please email me. Mhm.
I will pass them on to you
Of course.
later.
All right. Have a good night, everyone.
Thank you so much, Dr. Pereira, as always. We
Take
appreciate
care.
you so
Bye-bye.
much.
Bye-bye.
Guys, again, if you have any other questions, please send them on to me, and I will be sure to obviously pass them on to Dr. Pereira. And we will put this on our YouTube channel for others who might have missed this for tonight. So give me a couple days. I promise I will get this up on YouTube with my IT skills. It will be on there, I promise you guys.
I just want to say, hey, Jen. I know we haven't seen each other in a while. Hey, everybody that's up here.
Hello, Miss Shemaya. How are you?
I'm good.
Nice to see your face.
I know, right? We'll talk.
We will. We will catch up, I promise. All right, guys. Well, listen, I know it's late. I don't want to keep you any longer. So I thank you all very much for tuning in tonight.